Professor Com, La Réunion has been a key territory in the fight against chikungunya since the major epidemic in 2005. Considering this long-term endemic experience and the critical lessons learned over the last 2 decades, what specific insight can you share regarding the effectiveness and sustainability of Aedes vector control programs in a high-mobility insular context? And what advice does this provide for public health planning in mainland Europe?
Thank you for this interest for what happened in Réunion Island. As you underline, I think it's a very important example of what could happen elsewhere. So it's a very good idea to focus on what happened in Réunion Island over the 2 last decades. Because as you said, the first huge outbreak of chikungunya in Réunion Island occurred in 2005. And after that outbreak, it was estimated that the seroprevalence was around 60% of the population. And then nearly nothing happened during 20 years. And in 2025, as you know, there was a second huge outbreak, which was quite similar to the first one, and for which, unfortunately, we were not prepared, although there were vaccines available. So we have not been very good to manage this outbreak. On what did happen, how this outbreak was possible. It's just because the seroprevalence decreased a lot over the 2 last decades. I mean, after the first outbreak in 2005, the seroprevalence was around 60%, as I told you. And then 20 years later, the seroprevalence has decreased to about 20%. It was even less than 20%. It has been estimated to be to 18%. On first, this is this low prevalence which allows a new outbreak to occur. And probably it explains that there will be a 20-year cycle of chikungunya outbreaks in territories where the virus doesn't circulate a lot. And it's exactly what happened in Réunion Island. And the second thing which happened because of the Réunion Island epidemic was an increase of imported cases in France, in inland France, because we have a very close relationship between Réunion Island and France. And when there is an outbreak, either of chikungunya or dengue fever or Zika occurring in an overseas territories, French overseas territories, like Martinique, Guadeloupe, or Réunion Island, we have an increase of the autochthonous, of the, at first, imported cases in France, and then of autochthonous cases in France. And it's exactly what did happen in 2025, this summer, last summer in France. We have an increase of imported cases of chikungunya. We had about, I don't remember exactly the name, but it was about 1,000 imported cases. And unfortunately, it led to many autochthonous clusters of chikungunya in France because the mosquito, tiger mosquito, Aedes albopictus, is endemic now in France. So we have a lot of clusters. And it was more than clusters. It was even little epidemics because there were a chain of transmissions, autochthonous chain of transmission with secondary cases and tertiary cases which were no more related to imported cases, but just to autochthonous cases. And we have such small outbreaks small epidemics that occurred in south eastern part of France, south of France, and also western south of France as well. And unfortunately, it will happen also in other parts of France.
As the incoming president of the International Society for Travel Medicine, what will be your strategic priorities for the mandate? Specifically, given the global expansion of vector-borne infections, how can the ISTM better facilitate the sharing of best practices and epidemiological data among member countries, for example, through the GeoSentinel network, to address threats like chikungunya and dengue more effectively?
So the main goal of ISTM is to protect travelers. The main goal of ISTM is to make travel safe for people, to enjoy travel, to avoid travel-related illness, and to make traveling a positive event. So against mosquito-borne disease, fortunately, we have personal protective measures, but they are not efficient enough. So we are very lucky now to have vaccines against the two most important viral threats, that is to say, dengue fever and chikungunya. Unfortunately, we have nothing against malaria, I mean in terms of vaccine, because fortunately we have chemoprophylaxis. And as you know, malaria is one of the main concerns also in travelers, mainly for those going to Africa and those being friends, visiting friends and relatives.
And the recent approval of new vaccines against arboviruses, such as chikungunya vaccine, mark a significant turning point. How can the ISTM, under your leadership, work with regulatory bodies and the pharmaceutical industry to ensure equitable access and strategic adoption of these new preventative tools in travelers' health programs globally, particularly considering the economic and logistical disparity between countries worldwide?
So, as you probably know, I am not yet the president of the ISTM. I am just the president-elect. I will be the president of the ISTM in the following year, 2 years exactly. So your question is a little bit premature. But anyway, of course, we have very good relationship with pharmaceutical companies because we have the same goal, which is to protect travelers. On an important point is that while protecting travelers, we are also protecting our population, because as I said in the first part of the interview, travelers transmit diseases when they come back, when the mosquitoes, for instance, is present in your territory. So it leads to autochthonous cases, to clusters, and even, as we have seen in France this summer, to epidemics. So it's very important to protect travelers with vaccine, because if you protect travelers, you protect your own population against the importation of cases, and then you prevent the surge of endemic cases.